Undoubtedly joining us today because you also know that social workers must be at the table and engaged in the new community-based programs and policies that are being rolled out by the ACA. We're ideally positioned to ensure that the person is at the center of care, given our practice behaviors related to the psychosocial aspects of care and the social determinants of health. And we as social workers have the vitally needed skills for mental and behavioral health integration, as you will readily see by the completion of this webinar. The high demand for this webinar confirms for us that we are tapping a need for content on behavioral health and social work. And we hope you leave the webinar with ideas about how you can infuse competencies related to behavioral health, whether into your teaching or your practice. As you listen to the webinar, I encourage you to think about how well are we preparing our graduates for social work roles in primary care. Do our students even see this as a viable career path? And if not, what do we need to do to help them understand these options? And at the skill level, are we educating our graduates to translate their geriatric competencies in psychosocial assessment, engagement, motivational interviewing, care coordination, and systems change to be relevant to the primary care setting? And then that we think about how do we link these skills to the EPAS core competencies to engage in diversity and difference in practice so that we ensure that culturally competent care is provided in primary care settings. To address these and other questions, we're delighted that Suzanne Daub, LCSW and Senior Integrated Health Consultant for the National Council for Behavioral Health, is our presenter. Briefly, by way of background, Suzanne consults nationally with behavioral health organizations on the clinical aspects of integrated care, on operationalizing integration, and on building workforce skills. She is a lead consultant in the National Council's work with the states of Ohio and New Jersey on the Health Home Initiative and has trained over 50 organizations throughout the country on case management to care management. Prior to joining the National Council for Behavioral Health, Suzanne worked for 17 years as the Director of Behavioral Health in Primary Care at Delaware Valley Community Health, a federally qualified health center providing medical services to 44,000 poor and underserved Philadelphia residents. Using her knowledge and experience in integrated care in this health setting, Suzanne now runs the National Council's FQHC Lookalike Learning Community and is a coach for behavioral health business, where she works with behavioral health organizations in the area of strategic business planning. She has won several awards, including the Innovations Award from the Pennsylvania Association of Community Health Centers. As you can readily see, Suzanne is nationally respected for her leadership in the area of integrated care, and we are so fortunate that she could take time to present to us on this critical topic. Thank you, Suzanne.
Well, thank you, Nancy, and thank you to the CSWE Gero Ed Center as well as to the NASW for the opportunity to present on this topic. I'm very passionate that this is the place that social workers should be, and I am very happy to have this opportunity to tell you why. Let's take a look at, let's take a look at our agenda and see what the plan is for covering today. We're going to be first looking at the why behind integrating primary care and behavioral health. And part of the why behind that is going to also cover why social workers. At some point during this, we're going to look at our unique skills and what we bring to the table. We're going to define integrated care. We're going to review the skills that we need to practice in integrated settings and the areas of strength in the social work profession as well as where growth is needed so that we can enter this in a strong and competent way. And finally, we're going to look at what are the jobs available. As the ACA rolls out, there's plenty of opportunity, and we really will find that there's a lot of places within varying settings that we can show our presence. Okay, so let's move on to take a look at the why. What I think we need to first of all acknowledge is that during the last 25 years, there have, been a lot of publications suggesting that when patients have psychological or behavioral problems, they turn almost exclusively to the primary care medical office. They're not really going to traditional mental health and substance abuse services for care. In fact, this is so much the case that primary care has been called the de facto mental health system in the United States. So what you're going to see is somewhere between 40 and 60% of patients with psychological problems treated solely in primary medicine. And when we look at this slide, what we see is it's considerably higher in the elderly population, with up to 80% of elderly Americans with depression receiving their depression care in primary care. So, in primary care, depression, anxiety, panic, somatization, substance abuse, these are some of the most frequently encountered diagnostic presentations. However, 80% of the people who come to primary care come because of psychological distress, social distress, and present with physical symptoms. So in other words, they're not coming in and saying, I'm really depressed. They're coming in with headaches, with backaches, with kind of a somatic presentation. And I think this helps us to understand why only about half of the elderly patients presenting to primary care with depression are recognized as depressed, and why only 1 in 5 depressed older adults are receiving effective care in primary care. Because I think, what we're seeing is that they're treated with, a less intense intervention that they need. There's a lack of adherence. There's a lack of psychoeducation. And for many folks, there may be a lack of appropriate support and no one putting that support into place in the primary care arena. So we've established that many older adults prefer to receive their care for depression in primary care. And, one of the reasons is that it's just more efficient for the individual, right? Primary care providers can address not only your mental health problems, but they can address your acute concerns, your chronic medical conditions that are common and are so often comorbid with mental health problems, specifically with depression. So people get one-stop shopping, which we all desire and which is critical for the elderly, who can have upwards of 15 different medical specialists in their lives and can spend an inordinate amount of life energy shuttling between them. So anything that we can do to consolidate this, in fact, brings more satisfying care to the patient. And that is one of the 3 triple aims of the Affordable Care Act, is improved patient experience. So the other thing that happens when you go into primary care, because folks are seen over a lifetime and pretty consistently and regularly in primary care, is that we have this opportunity to track their depression over time. And this is very important in the elderly because depression is often either chronic or, in fact, recurrent. Several studies in the last 10 years have demonstrated that geriatric depression can be treated very effectively in primary care when mental health providers provide effective consultation and collaborative care. So when you insert the mental health provider into the scene, the quality of care and the outcomes of that care improve tremendously. Let's take a look at that. So there's one particular, these are two. So these are two studies that have been done and have now become actual approaches to care, integrated approaches to care. One is called IMPACT, which stands for Improving Mood, Promoting Access to Collaborative Treatment for Late Life Depression. And actually now they're just calling themselves collaborative care, or sometimes you'll hear the same thing called the Diamond Program. And then the other is prevention of suicide in primary care for the elderly. And that was a very large collaborative trial. So with the IMPACT project, there's really good evidence of clinical efficacy and cost offset. In this particular study, 1,800 depressed patients that were either 60 years old or greater enrolled in 18 different primary care clinics. And the patients were randomized either to care as usual, or they were assigned to this collaborative care, this IMPACT care, for up to 12 months. And so what did collaborative care look like? It looked like a nurse being supervised by a psychiatrist and a primary care provider. And this collaborative care nurse provided decision support on evidence-based antidepressant prescribing guidelines. And at 12 months, 45% of the intervention patients had a significant reduction in depression versus 19% in the usual care group, which is really pretty extraordinary. I mean, with most medical conditions, if we could get, double the response, we'd be very happy with that and consider it quite a powerful intervention. So after a full year after the patient study was completed, people who had received the intervention, again, fared significantly better than the controls. So the lesson learned there was that depression treatment with care managers can be effective, and effective in a chronically ill population and an elderly population, and the benefits can be lasting. So there's a lot to be said about this and a lot to really consider going forward with it. Let's take a look specifically at that ACA that I just mentioned. For most of us, the factors that are driving the Affordable Care Act and integration are well known to us. But I just want to make sure that we're all on the same page. What we need to consider is that approximately half of all patients in primary care present with psychiatric comorbidities. So 50% of the folks walking through the door for primary care in general have some kind of psychiatric comorbidity. And again, 60% of that psychiatric illness is treated in primary care. And until the last 15 to 20 years, there has not been a generalist level of care for mental health. So in other words, we basically had one option, and that option was to send people to therapy. And for a lot of folks, primary care is a far more acceptable context for receiving these services. There are a lot of barriers to getting into the mental health system. We look at things like cost, access, waiting lists, stigma, of course, service fit. In mental health clinics, there's generally, while we have a lot of different approaches and evidence-based approach, treatments that we can provide, generally, though, everybody gets therapy, whether they need it or not, right? We'll talk more about that a little bit later. There's also still system siloing and fragmentation, and for the elderly, this can be and for most of us, this can be very deadly, but to the elderly, this can be really considerably important because they're on a lot of medications, and if a psychiatrist adds more, but the primary care provider doesn't know about that, it can really be very harmful. So the central hope here of the ACA is that integrated care models are going to move us closer to these three aims of increasing access, of improving outcomes, and as I mentioned just a few moments ago, increasing patient satisfaction with their care. All right, so again, defining integrated care. As you can see, just based on this tree here, There's a lot of definitions floating around out there. As I mentioned, we've been working on this for the last 20 years or so, and this is a great graphic the Agency for Healthcare Research and Quality, or the AHRQ, put together. And it really illustrates the very wide range of terms that you'll hear. So you'll hear people say integrated care, shared care, patient-centered care, coordinated care, co-located care, collaborative care. And, people do mean different things by each one. There are definitions that people are speaking about, but often these terms are used very interchangeably, and we haven't gotten to a point yet where we really, have defined the definition, and maybe we never will. Maybe we don't need to. Today, what we're going to specifically be looking at is one of the elements on that tree, and that's the one that you'll see circled here in the middle, and that's integrated primary care, or what I call and what most people call primary care behavioral health. So that's what we're going to be focused on today. Okay, so primary care behavioral health. At its basic level, integrated care is when behavioral health and primary care providers work together to address physical and behavioral health needs of their patients. But specifically, what I want to talk about is where the primary care behavioral model differs from specialty mental health or secondary care. So, in medicine we have primary care, secondary care, specialty care, tertiary care, hospitalization. In mental health, we really just have a very well-developed secondary specialty care system, and we have a well-developed tertiary care system. But, what we're really trying to do is bring primary care mental health as a level of care into play here, and that's what primary care behavioral health does. So primary care behavioral health, one of the ways it's different is that it's population-based clinical care. So it's population-based, it's simultaneously co-located, collaborative, and integrated within the primary care clinic. And I want to spend a few minutes on this population-based care idea because it's completely central to integrated care. If you're not doing population-based care, you're really not doing integrated care. Population-based care emphasizes volume of care. The goal here is to impact the entire population and to shift the population in the direction of good health and well-being. So the big mental shift that we need to make is that when we're providing population-based care, we are responsible for the general care of a community of people. This is very different, obviously, from traditional mental health settings where high-intensity services, psychotherapy, are provided to a comparatively small percentage of the population. So in population-based care, what you're going to see is you're going to see a move toward a standardization of care across the population. And this took me a long time, coming from the mental health world and coming from, individual therapy world. This took me a long time to really wrap my head around because I was so used to focusing on one person at a time. And what happens in this primary care behavioral health model is that instead we're using algorithms, protocols, evidence-based assessment tools, and we're engaging in continuous improvement systems, implementing rapid change cycles. And instead of looking at patients one at a time, patient information is organized into what are called disease registries. These are in the electronic health record. And we are proactively using that data to reach out to identify and reach out to patients who need follow-up or need additional support to achieve better health outcomes. So through that, we can say, who needs referral to specialty care, who needs referral to social services, who needs referrals to community-based resources. And we can begin to track how that's going, who not only was referred, but who was linked. We can also track things like if we're treating the person for depression, we're measuring the depression based on a standardized measurement tool like the PH29, the Patient Health Questionnaire 9, which looks at depression symptoms. And we're getting a score. And then we can put that score into the registry, and we can look over time to see, how's that person doing? Are they getting better? And we can make decisions like, if they're not, do we need to do something? Do we need to talk about adding something else in, increasing medication, really pushing that person to implement some of the behavioral strategies that we've talked about. So you're really watching both the individual and the population. And if you start to notice, wow, none of our patients are really getting better, then you start to ask as a center, what else could we be doing generally for depression that we're not doing? Maybe there's something we need to add in on our side. Okay, so I want to just also talk to you a little bit about integrated care, further defining things a little bit. This is a framework that you'll see used quite a bit that distinguishes between a referral level, a co-located level, and an integrated level of care. Just taking a look for the moment at the referral level, there are some disadvantages with that level of care. There are also disadvantages with the co-located level of care that I want folks to be aware of. But I don't necessarily mean that integrated is the best for every patient. Some people do fine, patient one at a time now, not population-wise. Some people do fine with referral. Some people do very well with co-located care. But when we start to look at populations of folks, what we see at the referral level is that only about 25% of people that are sent to primary care sent to specialty care from primary care go. So only 1/4 of the people that the primary care provider recommends to therapy ever gets to therapy. And then the other problem is that there's minimal collaboration, so that the systems are very siloed and there aren't good structured pathways for communication between the two. So the primary care providers are super busy, maybe don't answer the phone, aren't that available. Sometimes as mental health providers, we hide behind confidentiality, and we don't just take the extra step of saying to the patient, how about if I work with your primary care provider together so that we can provide you whole care? Interestingly, this co-located model, what that basically means is you take a specialist, a therapist, right, and you bring that therapist on site into the primary care practice. And that is, in fact, an improvement in access. Theoretically, all you have to do is walk down the hall and you can get your therapy. What we see, though, is a very similar pattern of engagement, where only about 25% or so of the folks will actually engage, and they'll only come for that one visit. And then they're done. They don't want therapy, essentially, is what's happening there. So they're not essentially, even though the specialist is co-located, they're still actually not integrated. They're not working with the primary care practice toward developing a treatment plan together. So co-location does not necessarily equal integration, and it's pretty important that we keep that in mind and don't just stop there and think that that's going to be the solution. It's also the case that co-located care is generally not consistent with the primary care mission of delivering population-based care, and the model doesn't match the pace or the nature of the primary care setting. It's very likely that there's the wrong ratio of a number of behavioral health providers to primary care patients. So primary care, being all about efficiency, is going to start to feel like co-located care is inefficient and it costs too much. So in the center where I worked, for instance, we saw 44,000 people a year and there were 2 behavioral health specialists, if we were doing specialty care, we wouldn't have been able to provide very much care in terms of penetrating that population and really doing population-based care. And the providers would have viewed us as doing something special for a very few number of people that could find their way to us, but that otherwise we weren't really available to the general community, and there would have been a disconnect in a sense. So because of that, today we're going to focus the discussion on this integrated level of care where there's this very close collaboration. And in a sense, you're no longer practicing as a therapist. You're practicing as a primary care behavioral health provider. You're actually being a primary care provider using your behavioral health skills. I'd like to take a moment now to just really get into the nuts and bolts of that so that you get a feel for what that actually looks like. So we start with, first of all, we start with the sense that this is teamwork. This is not, as much as you're not treating one individual at a time, you're treating populations, you're not working one person at a time, you're working as a team. And because it's primary care, and by and large, we still are operating on a medical model, not everywhere, but for the most part, the primary care provider is seen as the team leader. So what I mean by that is that primary care providers have panels of patients. That's what they call them, okay? So one primary care provider usually has a panel of patients that's somewhere between 1,200 and 1,700 people that they are taking care of. We might think of that as kind of like our caseload. Those people are their responsibility. And they are responsible to do things like screen for trauma, screen for anxiety, and refer a broad range of patients to the variety of other people on that team. It could be to behavioral health, it could be to health educators, to nutritionists. Many teams have pharmacists. If you're really lucky, you have a social worker who's providing more traditional linkages to concrete services. And hopefully your team has a behavioral health provider on it. But the PCP remains accountable for the care. So in terms of what we're looking for is we're looking for a PCP who's not only going to refer behavioral health to the behavioral health provider, but that's also going to be referring health behavior issues. Because again, we want to get at that point where the co-occurring disorders are being attended to. So diabetics are consistently referred to the behavioral health provider. Folks that are experiencing sleep issues, folks that might be smoking, or that might be experiencing chronic pain, that those folks are going to be consistently referred. Nevertheless, the provider, the primary care provider, is going to be doing any kind of medication evaluation, obviously any kind of prescribing and monitoring of medication. But it may be in concert with a consultation from behavioral health. So let's look at behavioral health. So when we ask the question, okay, so what does primary care level of behavioral health consist of? What's different about it is that in this model, the behavioral health provider is acting as a consultant to the primary care provider. The primary care provider is your main customer. So the primary care provider, if we just think about it as that one doc treating the 1,700 people or whatever it is going to be approaching the person who's usually called, in this model, it's called a behavioral health consultant or a BHC. It's going to be approaching the BHC throughout the day, and it's going to be saying things like, I've got Mr. So-and-so in room 6. He has asthma, and I think his stress level is getting in the way of complying with it, or is making it worse. Can you work on that? Or Mrs. So-and-so in room 7 just got diagnosed with HIV, and it's really she's not making a good adjustment to this news. And you're essentially working side by side with that primary care provider and going into the room, same room, you don't have like your own office, you're consulting at the same time, same day with that person, and you're doing these maybe 15 to 30-minute consults in which what you're really trying to do is get a handle on the person's functional status, and you're trying to plan with that individual for functional restoration. So you're not going to be asking questions about their childhood, unless that's very pertinent. And if you were, it might be a question like, how does what happened during your childhood impact your goals and your desires today? How does it impact your ability to work, your ability to partner and parent, to do the things that are meaningful to you? So the BHC does not have a caseload. The BHC isn't going to be opening or closing cases, all these kinds of things that we do in outpatient mental health. This is not our caseload. It's the primary care provider's caseload. We're a consultant to them, so we are, kind of moving in and out of that space, and we're reimbursed by encounter, not by time, just like they are. Essentially, we're treated just like the primary care provider. We're documenting in their record, and the record is, our documentation format looks very much like a medical documentation note, a SOAP note. And there's no such thing as really like, a no-show, because if you ask someone to come back for a consultation in a week to further work on targeting this functional difficulty that they're having, and they don't come back for one reason or another, they're not a no-show. You're just still out there, available for these warm handoffs. So in that sense, you have to have trust and faith and belief that, in fact, you will see them again, because people use primary care intermittently over their lifetime. And if you don't catch them that day, or they didn't come back and you reached out and were non-responsive, chances are they're going to be back because they have a cold, or because they're back for a check on their blood sugar, or, for their pain medication, and you'll be able to catch them at that point. So I'm going to talk to you later about why this is a great role for a clinical social worker. But I'm imagining as you're listening to this, you can begin to put some of that together for yourself and begin to see why your skills as a clinical social worker might be a nice match for this. So basically, as I mentioned, we're really working here on a functional kind of contextual approach to assessment and treatment. You're working very fast. You're using the evidence-based models that hopefully you have good knowledge of, and that would be things like motivational interviewing, behavioral activation, acceptance and commitment therapy, or SBIRT. These are skills that hopefully you're in, really in deep with, and you know these skills, and you're modifying them essentially to the primary care environment, to those 15 to 30-minute visits, and you're also modifying them maybe even further to explain how to use them to the primary care provider, because they're going to see more people than you are, and one of the ways that you can contribute to the overall wellness of the population is by teaching the primary care provider what you know, so that they can apply it and not necessarily need to call you in to less complex cases. So the kinds of things, that behavioral health providers, behavioral health consultants do are listed here. A lot of problem solving, a lot of general coping strategies, a lot of patient education and just supportive listening happens in these environments. Looking further at it, the kinds of issues that you're going to find yourself encountering are, the usual mental health concerns, affective concerns, depression, anxiety. But what might be different in primary care is you're also going to be responding to a lot of physical illness, pain, chronic conditions, health behavior issues, obesity, smoking, Sleep is huge, medication adherence. Self-management of chronic conditions is almost maybe 90% of what you end up doing. And you're going to engage in a lot of prevention work. So these are things that I don't know that you necessarily get to all the time in outpatient therapy. Okay, and so here's the dance. We can just look at it briefly because I think I've gone over it quite a bit. The PCP is screening, providing these warm handoffs. Both are reviewing each other's notes because they're right there for each other in the electronic health record. You're regularly consulting about patients, changing and adjusting treatments if people are not meeting the treatment targets or their functioning is not improving. You're co-monitoring treatment, and if someone isn't responding to this level of care, you're working to help them and support them in making it to a higher level of care or specialty care. This is very patient-driven. So in other words, a lot of patients don't go because they don't want to go, or they're not ready to go, and there's a real recognition of that and a real sense of, okay, what can we do for you here? We're not just sitting around saying what you really need is therapy. We're really asking, what can we do for you here? So let's take a look at this, because this is a nice case example of someone that I worked with who I thought would be interesting to you guys, being that you're studying, working with the elderly. So this is Mrs. T, who is a 73-year-old African-American. And she has a lot of strengths. She's a retired teacher. She's, been an active participant in her church community. She's really a lovely woman, and she's at the same time struggling quite a bit with chronic pain, with hypertension. She's had multiple hospitalizations for coronary artery disease. And of late, she's quite depressed. She stopped going to church. She's missing her PCP appointments. And of most concern, she's taking her high blood pressure medication on what she calls on my own terms. So the primary care provider refers her to me, the behavioral health consultant, mostly because they're frustrated. So primary care providers tend to have a rather singular message of change or you're going to die. That's kind of their message, change or die. And as humans, we tend to respond to that message by getting scared and maybe changing a little bit for a little bit, but we tend overall to really shut down in the face of that message. So there can be this conflict between the message that the primary care person is delivering and the message that the patient is hearing. So he was very frustrated. This doc was very frustrated with her because she was not taking her medications consistently. She would run out of medications and not show up until like 3 or 4 weeks into that, having no medication for her high blood pressure, and being very symptomatic and, on the verge of hospitalization. And he had told her over and over again, this has got to change. So he said, would you please see her? So when I saw her, I did ask her, of course, do you know why your doc referred you and, what he's concerned about? And she did. And I said, I'd like to hear a little bit more about the rest of your life. Tell me about your daily life. And what I learned is that she has 4 grandkids under the age of 12 living with her. So she's 73 years old, and she is the sole caretaker for 4 grandkids, all of whom are school age, but I think the youngest was 6. And I was like, wow, that's amazing. How does that go for you? And she said, well, it's really hard. This isn't what I expected my life to look like at this point. I spend a lot of my energy taking care of them, getting them to school. We don't live in a great community. I don't want them walking to school by themselves. So, I'm doing a lot of kind of transporting, and it's really pretty exhausting. By the time they get into school, I go home, I take a nap, and then before I know it, I'm up going back to school to get them and then help them with their homework. So you can see she's well skilled as a teacher to care for these kids and help them through school age, but this is really not what she expected. So I said, well, what kind of help do you have? And she said, I really don't have any help. And I said, oh, their mom is in jail, their dads are kind of MIA, and she's been unsuccessful in engaging any of the other adults in these kids' lives to help them, saying, my sisters, speaking of her own, my sisters have their own problems, it's really all on me. So then I ask the question that's really critical here. I say, so if something happens to you, what happens to the kids? And she gets very passionate. So that's really what I'm looking for, and that's my skill set. I go for, what do you value? What's important to you? And she says, oh my gosh, what would happen to them if they would end up in the system? That's why I'm doing all this. I am not going to have my grandbabies in the system. I didn't have my kids in the system, and I'm not going to do this to my grandkids. And I said, so that is very important to you. And she said, yeah, that is really important to her. And over the next couple of minutes, we began to essentially connect the dots, right, by just saying, so how does that relate to your health? Where does your health come into play in terms of your grandkids and their future? And she was then able to sort of step back and see that taking her medication was, in fact, a form of caring for her grandchildren. So whereas before she was like, I don't have time for that, I just have to focus on them, I can't worry about this, I can't. In fact, she was probably scared to even really look at her own health issues because it was so threatening to their future. She was really able to look at it in this different way now. So, she then started taking her medication. And I mean, that's a really profound experience to speak with somebody for 20 minutes and really get down to what do you value, what's important to you. And, having her blood pressure stable gave her more energy, helped her to start feeling like she could manage some of this a little bit better, and helped us to begin to then say, could you make it to church? Could you reconnect with some other friends and build some resilience and protective factors into what was a very stressful situation? Okay, so here you can see, here's why we are perfect for this, because we are social workers. So we see folks in this very biopsychosocial way, and it's serious. We don't just give it lip service. We really take a biopsychosocial perspective as core to our approach. We bring, a lot of case management training into what we do. We're able to use these multiple lenses where we can go from macro to micro, where we can look at different systems, as I was doing with this woman, looking at her family system, looking at the environmental system. And we are really good at starting to unpack that and look at how do these things all interrelate. We also have a very strong, this is something, there are two things that we share here with primary care. One is a very strong ethical commitment to maximizing access to care. This is incredibly important to PCPs. And we are also, like PCPs, we are the broad scope generalists of the mental health disciplines. That they are the generalists of the medical profession, and we are the generalists of the mental health profession. So it's a very nice match. I think there are a lot of opportunities for social workers in primary care. A lot of these roles you're going to find in patient-centered medical homes as they're defined by the ACA. And these are the qualities that, the roles that you see up on this list on the slide here are all listed in the ACA. This is a really good opportunity for someone who enjoys fast-paced, multidisciplinary work, which we already have a big stake in because we have so many roles in our profession where we're working multidisciplinarily, right? Whether it be in child welfare or hospitals or the justice system, we are often representing a certain slice of a person's life among many other disciplines. So we're already pretty good at that. And it's a really exciting place to be. The other thing I want to say is it's a really good way to build workforce in this area is to build a program once you've got it kind of up and running and stable by inviting students, social work students, into this. I think this is hugely important. There is an urgent need to develop these competencies in integrated care. And while that does happen at some level in the academic environment, it's not happening nearly as much as is needed to keep up with the workforce demands in the practice environment and practicums of things. So I would really encourage everybody to think about these as unique opportunities for social workers where it's a good fit and you know, a fun opportunity. It's actually the most fun work I've ever done. What do we need to do if we want to work in a primary care setting? So basically, we need some enhanced training in these areas. We've got to understand these basic medical conditions. This was a real area of intimidation for me when I first got started, and you know, it took some time for me to understand it and to learn about it. The more education we can do in the classroom around these topics, the better. You know, people are whole people. The more, and 50% of people have some kind of chronic condition. So the more that we can educate folks about that, the more secure and confident they're going to feel going into settings. We've got to get better at rapid assessment and screening. We've got to really teach it, things like motivational interviewing, behavioral activation, self-management. These have to become part of the curriculum, but mostly what has to happen is we have to not only talk to people about it, we have to help them do it. Because these are not interventions that you can learn through talking about or reading about. These are interventions that you only get good at by doing it and getting good at doing it quickly. So for instance, primary care communication skills. You've got to learn how to talk to people in bullet points. And so often we really only know how to talk in paragraphs or novels sometimes, right? So we've got to begin to teach students to speak in short, declarative sentences that you know, get to the point and deliver our assessment as social workers without all the ancillary, I think, maybe, or in this case, but to really just say, here's what I think is going on. We've got to have a good working knowledge of psychopharmacology. We're going to be looked to assist in decision-making around that. Of course, not any kind of prescribing, but to be able to looked at to say, you know, do you think this person's ready to be on medication? Do you think you can help me with compliance and adherence issues through counseling? We've got to know how the medication should be used and at what doses and for how long and what typical side effects are of both psychotropic meds as well as, you know, medications that we commonly use to treat medical conditions. Okay, so, you know, with the passage of the ACA and the increased emphasis on patient-centered medical homes, integrated care is the gold standard. It is really, you know, our true north at this point as a country. We are trying very hard to do what they call bend the cost curve, to get the cost of medical care under control. And because psychosocial issues are driving most of the costs, we have a unique position and play a critical role in getting in there and really, you know, being part of that action. We are already well established in medical settings, so a lot of medical providers expect social workers to be part of their team. What they don't always expect is a clinical social worker, so we have to begin to be able to bring our clinical skills in, not just our care management skills, but our clinical skills in to say, you know, this is another way that we can assist you with these folks. But we are a great fit. Our values, our professional skill set is just a great fit for this type of work and this type of setting. All right, so that's my conclusion. I don't know if we have any questions that we want to address. These are some, you have in your slides, some resources that you can certainly use.
Wonderful. Suzanne, thank you so much for providing such an informative presentation. The questions have been pouring in. We've been collecting just a few for you to address.
Okay.
So take a couple minutes here. One of the first questions is actually about billing. One of our audience members is wondering how integrated sites are billing for services and whether this seems to be self-sustaining. Do you have any thoughts on that, Suzanne?
I have so many thoughts on that that I could not possibly answer that in a couple of minutes. But what I will say is that every state is handling this differently. And if you go to the Santa Rosa Center for Integrated Health Solutions, you will see state billing guidelines for every state in the country. The main thing to consider is that if you're going to take leadership in this area, you're going to want to work collaboratively with the payer to address a primary care level of behavioral health and payment for that. So payment is generally for the consultation. It's not for a time period. As we said earlier, it's not like if it's a 30-minute consultation, it's this much. If it's 15, it's this much. It's payment for the consultation. And in areas where they have pursued this, it has been self-sustaining and can be self-sustaining. Ideally, we would be functioning in a system where we would be looking at, and the research hasn't come in yet, it's still not robust enough, but it's hinting at the idea that there are cost offsets, that if you have a behaviorist in a setting like this, you're preventing utilization of higher levels of care, like emergency departments and hospitalizations. And so the cost offsets on the medical end, and if that's the case, do you really need to bill for the social worker, for the BHC, or do you really just need to let that person focus on doing their job and doing it well and doing both prevention as well as crisis work, and gain the advantage on the cost offset side? That's a brief answer to a very complex question, but a great question.
Wonderful, and thank you for providing those resources too. I'm sure that will be very helpful. So another question from the audience: how do you think patients will feel about warm handoffs, especially when they are not open to mental health care?
So this is really another great question. This is a patient-centered approach. So the patient decides what they want. And that's again, a complicated dance, because the doctor is essentially, or the medical provider, because they're not always doctors, the medical provider is essentially saying to the patient, in order for me to best help you, I need help also. I need some more information. So it's kind of the equivalent of saying, in order for me to treat your diabetes appropriately, you need to go get this lab test called a hemoglobin A1C so that I can see what your sugars have looked like over the last 3 months. So the doctor just says, that's what I need, right? There are people that walk out without getting their labs done because they decide they don't want to get, they don't want to get blood drawn. And that, then becomes something that they have to negotiate with the doctor. So in the same way, the doctor is probably going to say something, hopefully is going to say something like, you and I have run into an issue here that I can't resolve without some additional help. I have a colleague on staff that I use to further these conversations, and I'd like you to see that person. And the patient, might say, no, thank you. Or if you get into the room, you are going to say to the patient, here's what I do. I very strongly recommend not calling yourself a therapist. Because I think that isn't what you're doing, and it also, evokes a lot of other expectations. This is what I do. I work with health behavior. I work on stress reduction. I work with things like this. Your doctor's concerned about this. Are you concerned about it? Is this help that you feel you would like to take advantage of? And I'll tell you, in the 17 years that I've done this, I've had maybe a handful of people, literally 10 people, say, no, that's not something I want. So the vast majority of people are very open to it. And if somebody says, no, that's not what I want, then that's not what they get. You just say, okay, we are here for you. If you ever decide at some other point that that's something that we could help you with, please let us know. So that's basically how that's handled.
Wonderful. Thank you so much. So the next question is actually about primary care physicians, and this individual would like to know if there's any research or findings about physician participation and satisfaction in this type of model?
Yeah, so there is. There are some large studies, meaning, a few hundred physicians at a time, not thousands of physicians yet. But every study that is done points to increased satisfaction with their work when they have the opportunity to work side by side with a behavioral health consultant. Doctors want their patients to get better, and this is one of the most frustrating areas for them because they value it. They value the psychosocial drivers that are affecting health, the social determinants that affect health, but they don't often have the time to get into it in the way that they need to. And so they then feel like they're kind of walking through their day, doing halfway good or mediocre kind of, effort because, of the way medicine is structured. So in some ways, I have heard many physicians say this has really brought the joy back into practicing medicine because I can really work with colleagues that talk about the things that I know are important, bring that to the patients I'm taking care of, and I see people getting better in a way that's much more significant than, they took a pill and they got better. So our hope is that physicians, after working with behavioral health consultants after a while, are going to say, and often they do, I will never work again without a behavioral health consultant by my side. That's the goal. That's what you're aiming for in terms of physician satisfaction. You want them to say, I wouldn't do it again without your help.
Absolutely. So we're going to talk a little bit now about students and preparation for working in integrated care settings. And one of the questions from the audience is actually about her graduate program, specifically the mental health and healthcare concentration at her school. And she was curious if you think students in that particular concentration are academically prepared for internships in an integrated setting. What are your thoughts on that, Suzanne?
Having not seen the curriculum, I can't comment, with total knowledge on that. What I do know is that psychology tends to put out quite a few professionals that have a health concentration, and they are excellent matches for this kind of work. So if we're starting to bring some of the same kinds of things that they're learning, those kinds of health concentrations, into into this curriculum, I think we probably are preparing students quite well. The major issue, I believe, is are there practice opportunities in the field for students, and are there practice opportunities in the classroom so that the field is not the only place that you're practicing these skills. Again, as I said earlier, these are not skills that are just learned about and talked about. These are skills you must do. You have to practice introducing yourself to a patient. You have to practice motivational interviewing. So I would say if I was developing a curriculum, the curriculum would engage the student not only in learning the principles, but in also applying them both in the classroom and in a practice setting.
Wonderful. And Suzanne, we have just one last question for you. We're almost out of time. Suzanne, do you see this model working in specialty clinic settings?
That is something that is just beginning to happen. So I'm thinking a specialty clinic setting would be, say, a rheumatology clinic, a cardiology clinic. That is something that is just beginning to happen. So largely, this has been a primary care intervention. And I might add also that this has been a program that you'll see mainly in safety net settings. So you'll see this used widely in federally qualified health centers. You'll see it used very widely. It's been adopted by the Air Force. It's been adopted by the Veterans Administration, the VA health centers. And it's just creeping in also to commercial insurance, but very little. So in terms of specialty settings, I think there's a great role for behavioral health consultants, particularly around the area of group care, so that folks that are managing similar chronic conditions, say, arthritis or diabetes or something, have the opportunity to receive the medical care that they need, which is really, the visit that assesses, diagnoses, and determines, what medication they should be on and at what level and what dose for how long. But the rest of it, 90% of healthcare really is self-management. So that self-management is taught in groups by peers, by professionals, co-facilitating groups. I think that could be a very nice way that, we could begin to essentially influence the way care goes in specialty settings.
Well, thank you so much, Suzanne. I wish we had more time today, but we appreciate you again for providing such an informative webinar, and thank you all for joining us and listening to today's webinar. Please stay tuned for more webinars about the ACA and social work in the future. Thank you again.
It's my pleasure. Thank you for the opportunity. Take care.